So now we're going to look at atherosclerosis and arteriosclerosis. Big thing is make sure you know the difference. That arteriosclerosis is a thickening and hardening of the arterial wall, often associated with aging. Atherosclerosis is a type of arteriosclerosis, which is a formation of plaques within the arterial walls. And you usually see this within the larger arteries of the heart and of arteries such as the iliac or the carotids. This is a leading risk factor for cardiovascular disease. So the big push with both of these is to prevent a complete blockage or occlusion. With that being said, we want to lower that cholesterol level. And you're going to do that sometimes with lowering drugs for lowering the LDL levels, including the medications listed in table 33.5. You're also going to want to do lifestyle changes such as weight management, exercise, nutrition, low salt, low fat diets. They're going to want to do weight management. They're going to want to start exercising. You're going to want to make sure that they are looking at liver enzymes with the statin medications. So again, this is when patients already have this, when they already have atherosclerosis, arteriosclerosis, you want to make sure that you're trying your best to help them to modify the risk factors that can be modifiable. Keeping in mind that nutrition therapy or alterations in diet is the single most important intervention that patients with atherosclerosis or atherosclerosis can take. Peripheral arterial disease is a result of systemic atherosclerosis. It's a chronic condition, and the fear is that it's going to continue to worsen with the baby boomers aging and obesity here in the United States. African Americans are at a greater risk of PAD, primarily because of their risk factors of diabetes and hypertension. So what are some interventions we can do with these patients? We can encourage exercise. Exercising can improve arterial blood flow by increasing collateral circulation. You also can help these patients by looking at that action alert on page 712. It discusses making sure that they're not wearing tight-fitting clothing or using tight-fitting socks on their legs that will prevent blood flow. We want to make sure that we are continuing to promote vasodilation. With that being said, we want to make sure that the patients keep their legs warm, but not use direct heat on their legs because with decreased feeling, they may burn themselves. But you also want to encourage the patients to prevent exposure to cold because this can increase vasoconstriction. Patients are often placed on antiplatelet agents such as aspirin to help to circumvent around the atherosclerotic plaques. Another thing we may see are invasive procedures such as the percutaneous vascular intervention. With these interventions, there is a stent placed under guidance of fluoroscopy to help. It's a mesh-like device that will help to open up the vessel in order to allow blood to flow more freely. Surgical management is either inflow or outflow procedures. Inflow procedures, you have bypassing the arterial occlusion above the superficial femoral arteries. Outflow procedures involve surgical bypassing the arterial occlusion below the superficial femoral arteries. It's very important when caring for patients immediately after surgery that you familiarize yourself with where the dorsalis pedis or posterior tibial pulse is best palpated or heard by Doppler ultrasound. When you report off from one nurse to the other, whether it is post-anesthesia care or nurse to nurse, you should check these pulses together and make sure that you're documenting that change. Again, this is one of the national patient safety goals for improving staff communication, and it is listed on page 715. Here again, we have a review of the physical assessment findings with these patients. You're going to see pain that occurs even at rest. With the inflow disease, you're going to have discomfort in their lower back, buttocks, and thighs. In outflow disease, you'll see burning and cramping in calves and legs. I want you to take a moment and look at pages 711 and look at the foot there in figure 33.4. As you can see, looking at that, you have hair loss. You have that it is dry and scaly. It has rubra, or it is red in color. You have the horny toenails or thick calcified toenails. You have the blackened toe. All of these are signs of that severe arterial disease. These patients can have remember, we have been talking about peripheral arterial disease. With that being said, look at the arterial ulcers listed for us on page 712. Note that the edges are even. The ulcer bed is pale. It is seen between the toes. They are very painful. Again, that foot looks just like that fat with that black toe. You're seeing where they are in between the toes. They have pain at rest. Now, look over next to it with the venous ulcer. The venous ulcers are chronic non-healing ulcers. These patients usually don't have pain at rest. They may only have mild discomfort, where the arterial ulcer can be very painful. This ulcer bed is pink in color, and the edges are uneven. So these are just differences between the two types of ulcers. So what are some interventions these patients can take? Improving their exercise, positioning, promoting vasodilation, tobacco cessation, taking their antiplatelets, and controlling hypertension. This slide here refers back to the acute peripheral arterial occlusion, and the reason that to improve staff communication, we make sure that we're checking pulses together. When a patient has ischemia, you're going to see the pain, pallor, loss of pulses. Paresthesia, you're going to see paralysis and coolness to the touch. This is a medical emergency. Venous thrombus is a fancy word for blood clot in a vein. When you have a blood clot in your vein, they call it a thrombus. Deep vein thrombosis is the most common type of thrombophlebitis. It is more serious than superficial thrombophlebitis because it presents a greater risk of pulmonary embolus. So what is the difference between a deep vein thrombosis and an embolus? Well, the embolus is a dislodged blood clot that now travels to the pulmonary artery, and this is a medical emergency. But of course, pulmonary embolus are too exciting for this course because it's an emergency and will be covered in your 495 class. So right now, let's concentrate on preventing DVTs and preventing pulmonary embolus to begin with. So what we're going to do now is we're going to work on preventing that pulmonary embolus by preventing a deep vein thrombosis. And how are we going to do that? We're going to do that by using the venous thromboembolism core measure sets listed for us on page 721. This is where it talks about if patients have had surgery that they may need to have prophylaxis so that they do not develop a blood clot. Not only will providers prescribe low molecular weight heparin or heparin to decrease the risk of blood clot. There's also non-surgical management, such as leg exercises if they are still in bed, early ambulation, making sure they're hydrated, using graduated compression stockings, using sequential compression devices or SCDs. Again, making sure they're on the anticoagulant therapy or a low molecular weight therapy to make sure that they are preventing blood clots as much as possible. We as nurses can help to prevent deep vein thrombosis not only by following the prescribed orders by the physicians, but early ambulation, encouraging the patient to get up, making sure that they keep on their sequential compression devices, making sure that they are wearing the correct sized head hose. These are all things that we as nurses can do to help to prevent deep vein thrombosis. So now let's look at, despite all we've done to prevent this deep vein thrombosis, this patient has a deep vein thrombosis. Perhaps they were on a long flight and were sedentary for a long period of time. If you look at figure 33.8 on page 722, you'll see that the leg is swollen and that you have that leg will be tender to touch. They will have unilateral leg swelling. See how the one leg is swollen and the other one is not. They will have, you will see that they will need to be ordered a venous Doppler ultrasound to see if you can locate that deep vein thrombosis. Something that used to be done that is no longer indicated, and it states so on page 722, Hohmann's sign is not advised. And so I just want you to be aware that you may see that in older nurses who may not be up on their literature, but a Hohmann's sign is no longer advised with the risk of deep vein thrombosis. So when the patient has a deep vein thrombosis, you want to make sure you're elevating that extremity when they're in the bed or chair. Again, continuing with their compression stockings. You want to make sure that you're following the drug therapy. Anticoagulants are the drugs of choice for actual DVT and for patients at risk for DVT. The conventional treatment has been IV unfractionated heparin, followed by oral anticoagulants such as warfarin. However, unfractionated heparin can be problematic because of the patient's responses can be unpredictable. The use of low molecular weight heparin and the development of novel direct oral anticoagulants has changed the management of both DVTs and PEs. But with all that being said, whether the patient is on regular or is on unfractionated heparin, they're on low molecular weight heparin, what have you, the big thing to remember is regardless of the approach to anticoagulation therapy, all patients should be assessed before and during anticoagulant therapy for risks of bleeding. And all patients, remember, anticoagulants is still the drug of choice for actual DVTs or patients at risk for DVTs, no matter which anticoagulant they use. So make sure you look over the best practices for caring for patients receiving anticoagulant therapy on page 724.